It took me at least around 20 minutes to hear a horn honking over there. And if you ever want to experience how does a long distance relationship works, Dr. Govind Babu is there in Bangalore. You can actually ask him from one part of Bangalore to the other part of Bangalore how much time it takes. Okay, before we start this session, and I'm just stopgap arrangement. So who do you think should be moderating this session? Molecular tumor board, a pathologist or a clinician? Both are the last man politically correct one, and we are absolutely non-politically right people, especially in the light of what is happening in the last 10 days. Sir, whom do you think? Then one of us will step down.
Molecular pathologist is the best person.
Molecular pathologist, Dr. Amrit. Sir.
So usually with the multidisciplinary clinic we decide whether to go with what all things which routinely we do. Pathologists should reflex. They go for a routine test.
So who should moderate this tumor board?
Clinicians who train in molecular pathology.
Yeah.
Clinicians say molecular pathology.
He's also a clinician plus molecular pathology.
The presentation should go up to the diagnosis molecular pathologist. Once we talk about treatment, it has to be handed over to the clinician.
So both, okay, fine. Yes. Who should moderate? One of us will step down, I'm telling you this.
Mike?
Yes, we want mics.
Oh, the mics are there.
It can be very informal, sir.
It can be very informal. I am here to make it informal only. Okay, ma'am. Molecular. Dr. Amrit, they don't want me here.
No.
they won't want me here. all of them are saying. Okay, so do you guys have molecular tumor boards in your institute, Dr. Anita?
Yes, we do have, but it's selected cases get discussed. We just need a molecular diagnosis those we can, not all.
So what happens in molecular tumor board? What does not happen in a normal tumor board? I mean, you can just call them up and say, listen, I've got this mutation, that mutation. What really happens over there in the molecular tumor board?
Interpretation of the report is the most important.
Interpretation of the report, absolutely fine. I mean, yes, sir.
Yeah, the thing is in molecular tumor, but the problem is there are many different mutations.
Yes.
So it's very difficult to what's the penetration, what's the frequency. All these things are very difficult to interpret.
And sometimes, what happens in the report, the printed report, what will come is you will give capping positive and this positive and that positive, and then you actually go and talk to them and say, we have written it just for the heck of reporting that. So I think it's very, very important. I don't know whether they are young residents or not. I can see a young resident by the name of Dr. Govind Babu here, who is there in every molecular tumor board. But I think it's very important for us as medical oncologists to have a basic and more than a basic knowledge of a molecular oncology, because like it or not, in the 5 years time, molecular tumor boards NGS report is going to become the main point, and people who do not know how to practice it will be left out of that. And so I don't want to leave Dr. Amrit Kaler out. I have done my filler. You please start over there the case.
Thank you, Dr. Ullas. It's a pleasure sharing the stage with you. And we do have cases in which we need all the faculties on board. We need a medical consultant, we need a radiation oncologist, we need a molecular pathologist, and we need a genomist sometimes to help us understand few of the pocket points of binding EGFR with the special points to help us understand whether the treatment will work or not. So I would like to say I'm very happy that I am in this particular field. The reason is there was a time when we just had 6 months with the patient and there was only one type of chemotherapy for each particular cancer. But as we have grown, it's not only the morphological treatment that we are following, we are actually doing a molecular treatment for each and a different type of cancer. So we have come a long way in this cancer paradigm, and now we are able to do personalized treatments for different patients. So that's what motivates me, and it motivates us as a clinicians, as a scientist, that we can take this further. From 6 months, we have seen a patient with EGFR to 10 years of survival. So that's what motivates us, and that's what takes us a long way to do more and more for each and every patient differently. Thank you for inviting me. Dr. Sindhu, I think he has been my buddy all these 3-4 years. He has helped me, pushed me. Thank you, sir, for inviting me, and let's have this meaningful discussion and discuss this case and take it forward. We will need your input in all of them. Thank you, sir. Thank you, Dr. Ullas, for sharing the stage. So this is the case 1. This is the 52-year-old male.
Can I just stop you, Dr. Amrit?
Yes.
And that is what, you know, a molecular pathologist comes over there. The clinician will just come and say, the molecular pathologist will write a nice introduction and tell you everything about that. And, you know, we will just come and say, some Jefferson or osmotic we should give. How to structure a talk we should learn from the molecular pathologist. Ma'am, please come.
After we do that, it's very important to know whether the treatment worked or not. That's something where I go to the OPD and I go up to my oncologist and ask them what happened after that. Did the patient come back or not? So that's also very interesting, and thank you for doing that. That's so important. So we go to the case 1, and this is a 52-year-old male IT professional, and he was found breathless on a hiking trip. So X-ray showed a huge mass with a massive left pleural effusion. So as usual, the effusion was done and were sent for genetic evaluation. The CT thorax was done, which showed enhancing soft tissue nodule in the left lower lobe with the ipsilateral subpleural lung nodule and enhancing the left pleural nodules. So the pleural fluid in the histopathology showed some scattered mesothelial cells, few of them were atypical, and they showed cervical chromosome and hyperchromatism. IHC showed them positive for TTF1 and napsin, which confirmed a diagnosis of lung cancer. So the additional markers like pancytokeratin SCA was positive, CK7 was positive, which is supposed to be a lung cancer, and then PDL1 SPS SP263 was 3 to 4%. So the patient was started on chemo and pembro for 4 cycles, and then also there was a disease progression, but then the patient's biopsy was sent for 52 gene panel. And we saw that most of the important 9 to 11 genes which are targetable came out to be negative in this case, and the patient is still not responding to chemo and immuno. So on the report, what we saw was there was a kinase domain duplication by NGS testing. So this was easily missed on the 11 gene panel that we have done previously. So this patient also had an MS stable, tumor mutation burden was 4, and this kinase domain duplication was found to be positive. So Dr. Batra, you will take over.
So I have 2 concerns from here first. Here is where the first scan said, and you know you have a CD chest abdomen with a lot of pleural effusion, and a pleural filled cytology was present, number 1, and a PDL1 was 3 to 4%. Now this patient, I'll start with Dr. Anita. It doesn't look like an NGS has been done for this patient upfront, and the patient has been given pembrolizumab on the basis of a PDL1 3 to 4%. How does it happen? So there are 2 questions which I'll ask you. How comfortable are you in doing IHC on pleural filled cytology? How comfortable are you in getting a NGS on a pleural filled cytology and cell block? What do you normally send? Do you send a small panel, a medium panel, or you send the Patiala panel, which I normally say? Do you send a full CGP for everyone? So 3 questions I'll ask to everyone, but I'll start with you.
See, coming to the what panel do I send? I will not send the entire complete genomic at this point. Yes, it depends, limited to moderate panels up to 52 genes. That is the oncomine type of panel, because we also need to know not only the primary mutations but the co-mutations, because our co-mutation combination with the primary mutation will help us to decide therapy. So I need a little broader panel because we have drugs to play with.
So medium panel
Medium
is
panel is
and
enough.
are you happy in sending it on a cytology cell block?
Yeah, coming to that. If you have tissue, that's the best. But in this case, where fluid remains our thing, I would also suggest my pulmonologist do a wax biopsy of the pleura where you get a little bit of tissue. So I will send both the tissue, centrifuge pleural fluid,
Do a cell block.
do a cell block too. This is a difficult thing not many labs can do, but definitely very high specialized lab has the technique to make those cell blocks into blocks and go for
I think
it.
they have made, because there are a lot of IHCs on that. So I mean, they will not be able to. Then second thing which I will also look at this. I mean, look at the number of IHCs has been done, and again, Dr. Amrit, I'm just saying, and know this thing. I don't
Whether
think
it is
this-
needed or not.
whether it was needed or not.
In
I mean, if,
IHC
if you look at the IHC statement, they actually do 2 markers. P40, TDF1. If it is none, go ahead and do molecular marker. But invariably, when we find reports, there will be at least 20 IHCs which we done, including TDF1, mammoglobin, WT1, Paxate, everything would be done. So my first reaction on this is, I would probably not I would probably, so for me, the second point here is, cell block cytology is very good as long as the cellularity is more than 30%. So whenever you look at the NGS report, always look at the cellularity report. If the cellularity report is more than 30%, absolutely okay. Number one, cytology, cell block, whatever is absolutely okay. Yeah, please.
I'll just add one thing. If the cell block has a number of cells which is 500 to 1000 cells, if you don't get 30% cellularity, if you are able to count 500 tumor cells on the slide, because there will be inflammatory cells, there will be macrophages, there will be other fibrotic cells. So if you are able to see around 500 tumor cells on the slide, you can still proceed for NGS.
So also ask your pathologist about this. The point is, we just look at the final report. No pathologist will always tell us that what was the tumor cellularity. We have burnt our fingers, our hands, our everything. Cellularity 3%, I'll negative. We got a repeat biopsy done. Cellularity 20%, I'll positive IHC. The first and the foremost thing in the NGS report actually is to look at whether your baseline was right. If your baseline is not right, and there is something which many labs don't report in spite of telling everyone over there. A good standardized lab, the national, international lab will do. But one of the major reasons why we miss out on a lot of mutations is that because they don't do. The second point, so my first reaction is cytology, cell block is good enough. You do not require a biopsy, but please find out if there are more than 500 cells and the cellularity is more than 30%. That's the first thing to do. Yes.
One more challenge which we have faced in many of our cell blocks is the tumor heterogeneity. So if you take a section from the upper block, upper tissue, so we get different mutations. And sometimes we have repeated the NGS and the next sections, and we have seen that the mutation type is different. So there is a clonal population, there is a subclonal population. So there is a huge heterogeneity that we see even in the same block, not in different blocks. So that's why when Ma'am said 52 blocks, in one of them we will 50, 53. Next time we will see ALK, then we will see something else. So that's what is difficult to explain sometimes to everyone. It happens.
And one more thing which, yeah, sir.
Usually
Before we turn this panel into a dialogue conversation, we'll ask you also some question. We forget, no, sir, we talked a lot. Tell me, sir.
Before they decide the biopsy, always we find that the transbronchial biopsy has the least amount of tissue. So usually, before doing the IHC also we discuss the pathologist.
Yeah, so you
adequate tissue.
Need to talk to the pathologist. Listen, dude, we have a lung mass, we have a pleural effusion, we do not need so many IHCs. That's the first thing which we need to tell the pathologist, and we need to tell them, and like we have told our radiology people, that listen, we need this much tissue for biopsies. We need to sensitize our pathologists that we don't want TDF1 also, Napsin also, P40 also, P63 also, Paxate also, TDF1 also. For what? So that's the first thing. Second thing, cytology cell block is good enough. Third thing is very important. I think what Madam was saying was, sometimes what happens is half block goes over there to the pathology people who don't do in-house. The half block other than that goes over to the outsourced lab. Now that outsourced lab may not have tumor content. So it is the job of the pathologist to tell over there that listen this and look at a good report. What we have recently done in our hospital is just write a small thing, tissue is adequate for molecular based testing. Enough. Just write that. You should ask your pathologist. Pathologists are very smart people. They will not commit to unless or until you don't ask them to do. Tell them, it's absolutely okay. We do not go ahead till the time we tell them, okay, fine, cellularity is good or not. We ask them in black and white, give us a black and white answer on that. So that's the number 2 point.
So that depends on your requirement.
Yeah, that's obviously. Because if you don't ask, they will not tell you. Liquid biopsy will come to that, ma'am. We will also add to liquid biopsy. The second thing which came over here was this patient I have a strong objection to without doing I don't know whether it was done or not done, without doing NGS testing, please do not start the patient onto pembrolizumab in the first line. There are two reasons for that. A, we all know pembrolizumab does not work in a biomarker-driven cancer. B, even if the report comes as positive later, you have a chance of drug-induced pneumonitis. And third, very important thing is, if you have given, so we have had a patient just now, we got EGFR done from a local lab, came as negative. We gave him 15 cycles of pembro, pemcarb and an NGS done on the same low cellularity. It happens with us all the time. And we gave it, he was a part of clinical trial, progressed, we got a repeat biopsy done, we sent it to foundation and the EGFR is positive. Now since you have given pembrolizumab to that patient for 15 cycles or even 2 cycles, the half-life of pembrolizumab is 90 days. Please do not start the patient onto TKIs the next day. Again, how did we learn this? Because we gave it to one of the patients and the patient came to us with pneumonitis next day. And then somebody, juniors, read the book and said, sir, kya kar diya? Kyun de diya? I said, no, de diya. Then we gave steroids and stuff like that. So if you have given immunotherapy and if you have to give osimertinib or something, please make sure there is a gap of around 2.5 to 3 months before you go ahead and give them either a osimertinib or a capmatinib or something. Otherwise, not even a 3 crore rupee professional derivative is going to save you. Please do not start anybody on immunotherapy without at least an EGFR and basically if you can get an NGS sample, that will be fantastic. So what we do is we give 1 cycle pemcarb, we wait for the NGS report, second cycle the NGS report comes positive, you stop chemotherapy or add EGFR TKI to this. If it comes as positive negative, you add immunotherapy to it. So that's the protocol you follow. Please don't be in a hurry to jump off. People want to start the treatment yesterday. It is our job to not listen to them. That's very important. The third thing, Dr. Amrit, with your permission, if I can take the Oncomine 52 gene panel. Sir, which panel do you send?
I usually prefer to go 12 gene panel.
12 gene panel.
Usually again 12 gene panel is positive gene. Almost 12.5.
Even lesser if you are good friends with Novartis.
The rest is going to be 6,000-7,000.
Yes, sir.
Otherwise, very limited patient I put on EGFR course.
Only.
Okay. Because they are very economically constrained.
Fantastic. So 12 gene panel is what you will.
Yes.
Sir, what will you do?
I usually say comprehensive.
Comprehensive. So from 12 gene panel to a Patiala panel. And Dr. Anita has already said she is a 52 gene. So we have good democracy coming up. 52 and 12. Okay. So we are by and large. Yes.
So that depends upon what I am planning. So if the patient is looking for some tablets, it's always 12 gene panel. But if I am looking for an immunotherapy, then definitely an extended panel, but I will send an FDA approved panel. I burn my fingers multiple times sending an Indian panel to clinical genes.
We all
When they
have.
are not standardized.
Yes.
When you do multiple things on a small specimen, most of the time you will not get it correct.
Correct. If you are
So if you wanted to do a full panel, it has to be an FDA approved test. But if you wanted to do an abbreviated panel like 12G, most of the Indian labs are doing fantastically well. I am happy with them. Their report is good. But anything beyond that, I think it has to be an FDA approved test. It should have TMB because the 52 panel gene, 75 panel gene is not going to give you TMB. They only give you, they have said they have done this much of genes and this year you take. They will not give you TMB. It will not give you MSI. It will not give you HRE. It is one way or other way. There are multiple ways to calculate HRE. And it's not only about the first page of the report. Pages are there are multiple pages comes after that. The quality of pages comes after the first page. It's also different when you do an
Absolutely right. Absolutely with you on that. Don't even read the first one. It is there. The second, third, fourth are more important than ma'am.
So definitely EGFR I'll get lost and then rest is to the medical oncologist.
And the rest of the medical oncologist. Yes.
So what I do, I practice is whenever any patient with cancer or cancer comes, so we have an 11 or 12 panel in house. We screen all the patients for that. That if there's a targeted treatment applicable to that patient, so we can start right away. If not, then period one is fine. Start pushing the tumor. We do a bigger panel
So we have an in-house panel, which is the 34 gene panel. Again, panels are something which is oft repeated. NGS panel is not, so you have a backward resort here, you have backward resort everywhere else. It's different. There are certain differences. First of all, you ask your the lab which is doing is, do you do a DNA based panel? Do you do an RNA based panel? If you do only a DNA based panel and say that we are not getting our fusions, that is almost like you are coming to Delhi and saying that you are not getting beaches. I mean, you are not supposed to get beaches. Your NGS panel needs to include the DNA and the RNA. A rule of the thumb is, if you are looking for a mutation, that is if you do a EGFR or a BRAF or any other mutation, look for a DNA based panel. If you are looking for fusions, look for an RNA based panel. If your lab is not doing the RNA based panel, you are not going to get the fusions in that. So that is also very, very important. Talk to the molecular pathologist.